So welcome to another segment in our series, The Power of Pivoting, Managing Through Crisis, the Hospital for Special Surgery's response to the COVID-19 pandemic. I'm Dr. Ronald McKenzie, an internist and rheumatologist at HSS, who has served as the moderator for these discussions. Now, in previous sessions, we've talked about the administrative and the clinical response to COVID-19, even how it has impacted our educational efforts. So today, we shift the focus to cover the area of research. And in order to do that, we've invited two of our most distinguished leaders, both scientists, amongst other important roles, Dr. Peggy Crow, the physician-in-chief and chair of the Department of Medicine, in other words, my boss, and Lionel Ivashkiv, our chief scientific officer. So welcome, Peggy and Lionel. So what are the challenges you've faced? How have our scientists responded? And what has the research enterprise at HSS been up to over the last 2 months?
Well, I'll start. This epidemic came on us very acutely around the middle of March. I think we could see it coming, but I don't think we realized how it would have such a global impact on everything we do at HSS. As you said, I'm the physician-in-chief, and so my primary responsibility for particularly the first few weeks was helping to transform HSS into a completely different hospital and the role of our physicians in Department of Medicine into very different roles than they've been used to. But as a researcher at heart, it became immediately clear to me that the COVID-19 illness presented such fantastic and fascinating opportunities to make a difference to the patients, understand something about that disease, but then also learn from it with reference to our autoimmune rheumatologic diseases that we've focused on for so many years here. And Lionel and I connected up, I think, in the first couple of weeks of the epidemic and really worked together to reach out to New York Hospital, organize some efforts here at HSS. And I think we've really made tremendous progress in putting in place some very interesting research initiatives.
Any thoughts, Lionel?
Yeah, so I think it became clear to both of us and many of us here scientifically that the reason that patients with COVID-19 really get sick in this so-called second wave of disease has to do with the inflammatory and pathways that we all, and autoimmune pathways that we've all been studying, interferons, which are important for lupus. And we felt, I think, early on that we really, if we would bring a different perspective to this research, and if only we could become involved, we could make a difference. And I think that led to us reaching out and starting collaborations with scientists at New York Presbyterian. Mirella Salvatore was our first connection. But then what was really unexpected is with the overflow and just the sort of overwhelming nature of this crisis, that our hospital, HSS, started taking these COVID-19 patients as transfers and then as direct admits from the ER. I think we were involved in paying attention to what was going on, and we felt that it would be really important to study these patients while they were here, so we could identify, what pathways are really causing them to decompensate, and could we come up with new therapies. So I think in this first, which is a very exciting and crazy phase of research for us, and we worked very closely together on this, and also with really a multidisciplinary team that included anesthesia, ID, the frontline providers, the hospitalists. So as we were trying to design interventional studies that we could do here based on our special knowledge that could help patients. And it was really exciting. I don't know, Peggy, what you thought of that period.
Well, it's so interesting to think back on where we were right, say, the first 2 weeks in March. Lionel and I, along with a few others, had been just starting to think about how we might develop a research program focused on lupus, and had some ideas about some of the molecular pathways, what goes on with the cells in lupus, that we could dig into and investigate in the context of a new research program. And then comes along this COVID-19, and I think it occurred to both of us that these very same molecular pathways, these same mediators of the immune system, but perhaps in a very accelerated time frame, might be very relevant to COVID-19, and also might provide therapeutic targets and ways we could actually start moving toward helping patients.
So to frame some of this discussion, it occurs to me that at the onset of this pandemic and its arrival here, that we all, I think, conceptualized this to be an infectious disease, that it was a virus. It was really going to be the purview of the infectious disease specialists and then physicians who would be involved in patients with critical care. And as it emerged, it was clear that it had additional dimensions, which is, I think, the surprising relevance that it has to all of us with interests in autoimmunity and immune diseases. So, as I understand it, the body's immune response to the virus, particularly if we're talking about the pulmonary component of the disease, is very active in the threat that it imposes to people. And it, of course, then offers the opportunity for therapies that are not so much directed at the infection, but actually the consequences of the infection. Can both of you expound on that simplistic way of thinking about it a little?
Well, I'll try. As a non-virologist, I've still been fascinated by viruses for years, and in many ways I've developed my own research interests related to lupus in the context of how the immune system reacts to virus infection. And that led me over the years to study interferon, which is it's really a family of molecules produced by the immune system that fights infection, particularly viral infection. But what I've learned over the years studying lupus is that interferon, while it's a good thing fighting viruses, it can be a bad thing when the production of interferon and its effects are sustained over many, many years. So when we started learning about COVID-19, I think we immediately thought, and both Lionel and I were I think on the same wavelength here. We thought, well, interferon must play a role. It probably plays a protective role early in the disease, but we very quickly looked back at some of the old literature looking at the effect of the previous coronaviruses on the immune system, and noticed that the interferon wasn't behaving exactly as you would hope it would in those other coronavirus infections. And perhaps it was acting in a way that wasn't sufficiently protective, but might also lead to an exuberant inflammatory response. So, I think we were looking very, very closely at this dynamic between protection mediated by interferon and damage mediated by an inflammatory response, and thinking about, how might that balance be shifted in these coronavirus infected patients that we were seeing here at HSS and across the street at Cornell. And that led us to have some ideas about potential therapeutic approaches that we continue to discuss, some implemented.
So it's not as simple, though, a matter, or is it, that some interferon is good and too much is bad?
I think we honestly don't know. And we're talking about research here today. And I think we all have to recognize that this is a disease that's never been precisely seen before. There are similar diseases, but nothing quite like this. And we have to develop our plans and organize ourselves and get funding to be able to study patients with this infection, because I think we don't quite know. Is it too late? Is it not enough? Is it too little? Is it too much? Are there special shifts in the immune response that might be based on the genetic predispositions of one person versus another, or their pre-existing conditions such as chronic disease, chronic hypertension, heart disease, all of those sorts of risk factors that we've heard about. So I think we don't know the answer, and that's why research is so important.
Of course, there are other mediators of inflammation, cytokines and so on. These are interests of yours, Lionel, as a scientist. Can you comment on those and how they led to some therapeutic decisions?
Yeah, so, one of the first things I think we all heard about this was the cytokine storm. And the cytokine storm is at least one of the things that really causes damage to patients' lungs and causes severe complications of this disease. And some of the cytokines that are very likely involved in this, for example, interleukin-6, IL-6, and we think interleukin-1 or IL-1 are very much the same cytokines that are pathogenic in inflammatory diseases, especially rheumatoid arthritis and some of the juvenile inflammatory arthritides. So I think that this really linked the pathogenesis of COVID-19 in a very rapid and uncontrolled way to I think what we're seeing evolve over years in the rheumatic diseases that we've been studying. And to sort of give my perspective on the interferon question, I think it's very complicated because the interferon also can imprint a certain epigenetic memory on immune cells, which both can help protect against viruses, but then once the infection resolves, it leaves you very susceptible to environmental insults. And this has been one of our ideas of what might be going on in this disease. And one of our colleagues in the immunology program across the street has actually started getting some evidence for something like this. So we feel, the molecules we've been studying, the ideas that we've had, it's all playing out here. And I think we've both felt this almost urgent need to jump in and try to do something. And that reminded me that, one of the frustrations with all this was that we did have to close the laboratories. So we closed the laboratories on March 18th for anything other than essential research. But essential research included COVID-19 research. And I think one of the really great things to see was there's this wellspring of volunteers and people who wanted to work on COVID-19. So we've started various projects in the lab now. One sort of translational research linked to patient samples, but also more basic questions, trying to understand how does the virus activate immune cells? How does the virus even get into immune cells? And I feel it's the same thing. The molecules we've been studying in the lab are exactly those that this virus exploits to make people sick.
Mm-hmm. So what about the therapeutic implications then of that science?
I had what I consider the good fortune to become very involved with one of our young rheumatologists who has joint appointments, as we all do, at New York Hospital, Weill Cornell, and HSS, but she spends a bit more time at Cornell and New York Hospital than at HSS. And she was actually on the front lines taking care of COVID-19 patients admitted to New York Hospital. And Lionel referred to the very compressed time frame through which COVID-19 plays out in relation to the much longer time frame that we see in rheumatic disease. But at the patient level, I mean, that time frame was so evident and really changed the way I think we thought about therapy and therapeutic intervention. So our colleague over across the street was actually taking care of these patients, and those who develop severe disease would really be on the threshold of being intubated, being put on a respirator in the ICUs. And she had had some experience at her previous institution treating rheumatic disease patients with one of these anti-inflammatory drugs that targets IL-1 that Lionel mentioned. And she, based on her experience and really all of our experience with patients with systemic manifestations of rheumatic disease, thought that that particular treatment might be helpful in those patients. And the challenge, though, and it's really a characteristic of medicine and well-done science, that we want to do well-designed, controlled studies whenever we do research. And yet here we had patients who within hours might be intubated, put on a respirator, and the odds of getting off a respirator are not so great for this disease. So somehow working together, she and I kind of wound our way through the politics and the infrastructure of patient care and academics at Weill Cornell and New York Hospital, and kind of found a way to try this medication in some patients, but do it in a well-documented way with a sense of criteria for who might be appropriate to be treated with this drug and how we would measure the outcome. So all of that, I think, was fairly successful, with some patients doing well. Patients who didn't do well, we were able to understand perhaps why that was, and now we're working on developing a controlled clinical trial. So that's all to say that I think our background, our information about the immune system, our experience with systemic rheumatic diseases, and our knowledge of therapeutics can all come together to help these patients with very serious disease.
Any thoughts on that, Lionel?
Yeah, I think it really was one of the challenges. And we actually started a group that we call the Interventional Trials CRP, or Clinical Review Panel, where we were trying to develop our own ideas about how to treat patients at HSS. And one of the challenges was really an ethical challenge. Was you felt that you knew what would really work, but at the same time, you had to work with the trialists and the methodologists to design trials. And there, this tension between controlled trials where somebody might not get the medication versus trying it in the way that Peggy mentioned. I thought it was something that we at HSS really rose to the occasion. The group of people that we worked with was amazing. I think the support we had from the IRB and research administration, and sort of bypassing all of our, the sort of bureaucracy essentially, and getting things reviewed in 24 hours. I thought it was really rewarding to be part of something like that.
Yeah, I think that was a really unprecedented aspect of this experience. And somewhat on an ethical, from an ethical point of view, there's another element that occurred to me that I think we've all seen, that the research conducted in the COVID environment by necessity occurred at warp speed. And so what do you think has happened, though, to the norms that govern publication? It's really quite unbelievable to me to see papers, even in distinguished journals, New England Journal, reporting the experience of patients that were maybe in hospital a month before. I mean, it's literally unprecedented. I don't think in our careers we've seen anything like that. And it of course speaks to the magnitude of the threat and the acuity of the illness, but there had to be some bending of the rules of publication in order for us to see that. And apart from that observation, did you have any sense that there were the risks associated with that in terms of misinformation?
I think it's a very mixed bag. It's been fantastic how the usual maybe a bit paranoia of the scientist has been overcome with this acute threat and challenge. So, as you say, the pace of publication and pre-publication has been extraordinary. I mean, the sharing of data that never would have occurred before this has been fantastic. Every day there are new manuscripts deposited in the public for public access, and we can all look at them, and we all do look at them. The downside is, as you suggest, that they're not necessarily as well done as what we're used to seeing in published papers, or even, pre-published or submitted papers. And so, I think it's fantastic. It's wonderful. It's so much information to capture and process and synthesize, but I think we have to have a critical view of the data. No doubt the quality of the published papers in some very high-ranking journals is not quite what we're used to, but I guess my view is it's better to get the information out there as long as we can look at it critically, because all the information we can get, the better we'll be able to understand and treat this disease.
Yeah, I feel there was just this onslaught of information, and usually we have the time to filter it, and I think mistakes are made, and it's a self-correcting process, and I think we're already seeing that, and sort of seeing some of these papers from the preprint stage to when and there are better papers coming out now. I feel the most recent set of papers are better, so we're returning to the normal. But it almost required a different approach to keeping up with the literature, which I also found rewarding. You can't just read it all yourself. You had to be part of a group. We had a group in my lab where we surveyed papers, and we all shared these papers. And I think even so, I found it's just too much to keep up with. I think the fact that these preprint servers have been very well established prior to this really helped change the whole landscape here. And overall, I think it's been a positive. I think it's been better that we got the data right away.
Yeah, I think I'd agree with that. In the old system, meaning 2 months ago, I think the information we would acquire was very filtered. It was an extremely regulated kind of system. This, I think, essentially says, here's some observations, and as clinicians, do what you can with it. And I think it really shifted the responsibilities to the practicing physician to make the decision about whether he or she believed the information and believed it sufficiently to respond to it. And I think that was a very important shift. It was important for the time and the circumstance, but maybe it will change things going forward.
I think many of the researchers are not the same people who take care of patients. And yet, I think they felt that they wanted to help. And by getting their data out quickly, that was how they could help the whole situation. And I think it has.
I mean, the other thing that was striking to me was how the sources of that information were literally global.
Well, we hear and know about the tensions, for example, between the United States and China that have perhaps been exacerbated by this epidemic. At the same time, much of the data, during the first month or so, and still, that was published in these pre-publication forms was coming from China. And I think we needed to look at that data as critically as we would any data, but scientists there were as committed to move the understanding of the disease forward as much as any others.
The other thing that was striking to me, and we're all relatively contemporary, was probably the last time we saw anything of this nature was when AIDS descended on New York City. So that's 30 years ago. And to contrast the circumstances for a clinician at that time versus now is really just remarkable, both in terms of the information we had, the pace in which science could address the basic science and pathophysiology of the condition, and even lead to therapy.
Yeah, I was actually just thinking about that because I'm not on the front lines, certainly in this pandemic, but I was an intern and resident at Bellevue when AIDS became epidemic, and I remember being on medical services where 90% of the patients had HIV disease, and it was so slow. The disease had a very different pace, but I think the response to it was so different. And I was wondering if something like HIV was to appear now, of how much more quickly. I think you have to decide to respond first. And I think with HIV, it was let go for a very long time for a variety of reasons.
Yeah, it had a different kind of social dynamic associated with it. But we didn't know what caused it for probably 2 years, with extremely chronically ill and acutely ill patients, and nothing really much to do for them.
Thinking back to the period when HIV disease, AIDS, was prevalent around New York City, I think we were terrified. It was very fearsome. And while there is quite a bit of fear now with COVID-19, I think that there is a better grasp of what the disease is, what the virus is, that has allowed us all to handle this better and perhaps tackle it in a more successful, at least more timely way.
Well, Peggy and Lionel, listen, thank you very much for this. This is really one of the, I think, most exciting and sort of positive aspects of the COVID-19 experience, and we're really happy to share that with the audience. Thank you.